Hi, my name is Dr. Christine Schneider. I am the CEO of Integrative Mind Institute in Kirkwood, Missouri. The point of this presentation, Neurofeedback, a primary or adjunctive treatment, is really to help therapists in the area figure out who they may refer to us, what is neurofeedback in general, and how we can coordinate care for those clients of theirs who either don't do as well as they need to in talk therapy or just want to have an adjunctive treatment to speed up the process. So the first question is, what is neurofeedback? And neurofeedback is basically a computer interface that reads EEG brainwaves and gives near instantaneous feedback. So there's nothing actually going into the brain. What we're doing is reading brainwaves through EEG technology and using operant conditioning to help the brain learn more adaptive waves. There are many empirically supported uses of neurofeedback. Neurofeedback is a growing field, and so we really want to make sure we're staying within the realm of what is empirically supported. One of the biggest referrals that we get are for trauma clients. There have been lots of studies that talk about trauma treatment and the impact that neurofeedback can have in helping these clients who are struggling with doing standard trauma treatment and it helping with PTSD symptomatology. And for those of you who are trauma therapists, as am I, I've been a trauma therapist for close to 30 years now. I'm trained in EMDR and IFS and cognitive behavioral and schema therapy and all the things. And yet I was still really struggling to help our clients who had excessive hypervigilance, dissociation, risky behaviors, attachment injuries, all of these things that were preventing my trauma clients from getting the help that they really needed, or at least the resilience they needed. Another really empirically supported use of neurofeedback is ADHD. Again, clients with ADHD can really struggle to improve with standard treatments. We can teach them how to organize themselves externally, but sometimes that lack of focus or organization really can defer the therapy process, even in getting them to schedule and show up on time. Other people with ADHD just aren't good candidates for ADHD medications, either because they have side effects from it, there's an addiction history, or just frankly, they aren't somebody who wants to be able to take stimulant medication. A third area is peak performance. And these are clients, sometimes they're athletes, other peak performers. We see a lot of musicians, a lot of C-suite executives who really want their cognitive capacity to work at its best and to have superior self-regulatory skills. The final is TBI, or cognitive issues. Clients who have TBIs tend to struggle with things like forgetting, lack of focus, dissociation, and lots of emotional dysregulation. And neurofeedback is found to be incredibly empirically supportive for these individuals. One of the first things we do when we get a client for neurofeedback is to do what's called a quantitative EEG brain map, or QEEG. Basically, what a QEEG is a computational analysis of EEG waves. And so we take recordings of somebody's brain waves with eyes open, eyes closed, and sometimes with a cognitive challenge. And we can figure out with quantitative analysis what parts of the brain are operating suboptimally, what parts of the brain are in dominant wavelengths that just aren't suiting the client. And this can help us really figure out treatment planning. The other thing it can help, the QEEG alone, both in studies and our clinical practice, has really shown to be an effective treatment in itself to help the client know about the knowledge of their brain. It can increase shame resilience. It can allow them to work within the strengths or limitations of their brain. So for instance, a client who is having self-harming behavior, Well, it may show up that their hindbrain is activated and their language centers are not optimized. Well, this can help the client to realize while they're acting out behaviors instead of using language. Another thing we can do with the QEEG mapping is Loretta and spectral imaging. So Loretta imaging allows the practitioner to explain to the client where the generator in the brain is actually at that's causing the dysfunction. So for instance, with a trauma client, we can use Loretta mapping to show it's actually your amygdala that's causing a lot of the problems. And so this can help us to focus our training very specifically. It also can just help the client get a look at where the dysfunction in the brain is happening. Spectral imaging can give a sort of more broader sense of what's going on in the brain. And in each portion of the brain, whether it's the frontal lobe, parietal lobe, occipital lobe, the central motor strip, the parietal lobes, temporal lobes, what parts of the brain are operating in which brain length and brain wave, and whether or not that's functional for the client. So in each of these 4 categories, we have different goals for neurofeedback, right? With trauma clients, our goals might be to improve self-regulation, to help the client rest in a sense of safety that allows the attachment relationship to ease up and move them towards a more secure attachment. It may be just to have less PTSD symptomatology, meaning less shame, less hopelessness, less helplessness, or less avoidance of the trauma. And improved sleep is always a thing with neurofeedback and one of the first focuses we have. For ADHD clients, it may be a more increase in focus, a decrease in impulsivity. What's been shown in ADHD is that 20 sessions of neurofeedback have none of the side effects, none of the negative side effects of stimulants, including the addictive side effects. And also, after we stop treatment, the effect size continues to improve for 6 months. So unlike stimulants where you have to continue to take them, neurofeedback continues to improve in effect size long after you finish treatment. For peak performance clients, we really work on increasing a cognitive focus, improving performance through relaxed attentive waves and decreased rumination. And again, we're always going to hit sleep for these clients because these clients who tend to be peak performers do tend to struggle with sleep. For TBI and cognitive issues, again, increasing focus and attention, their ability to self-regulate, cognitive focus, and forgetfulness and impulsivity. So the question for those of you who have watched this far, thank you very much. The question we always get is how do we refer, and then how do I coordinate care once I've referred? If I refer to you guys, does that mean I stop being their therapist? Which many times is the exact opposite of what we want. We want many times to work in combination with a therapist rather than taking over as a primary therapist. Now, there are times where neurofeedback is the primary treatment, right? Something like ADHD, peak performance, TBIs, many times these people aren't going to do well in typical talk therapy, and actually neurofeedback needs to be the primary treatment. But most times I would say neurofeedback really comes in as an adjunctive treatment, meaning the clients are in a working therapeutic relationship, but either they're struggling to make progress due to, if it's trauma, controlling behaviors, avoidance, risky behaviors, or if it's ADHD, they can't focus enough to come in to make most use of the treatment, or they hit a barrier to progress, so they've been doing well so far. We see this a lot in trauma work where the client has done okay until they really have to do trauma processing, and then they struggle to either manage their affective states or they struggle to do the deeper processing that they need to do to hit resolution. In this sort of situation, the client continues in their primary therapy, but sees the neurofeedback practitioner just adjunctively. In that case, we work really closely with the primary therapist to talk about where the brain is at as far as regulation, so that the primary therapist can know when to push further into the trauma work. The third possibility is neurofeedback as stabilization. So clients who aren't able to do talk therapy, maybe because of self-harming behaviors, addictive behaviors, or excessive transference that's playing out and blocking treatment, they may need to take a break from talk therapy to go do 10, 15, 20 sessions of neurofeedback, but the plan is always to return to their primary therapist once they're stabilized. So at that point, the neurofeedback practitioner is monitoring stabilization and communicating with the primary therapist about when the client is ready to come back to their primary therapist. So our team is forever expanding. We have 4 of us now who actually are certified BCN practitioners. Elizabeth Irwin and I are certified supervisors. And we have more up and coming in the training BCN world. We're really coming in and wanting to be a resource for people in St. Louis, both in giving more information on neurofeedback because we've seen all the good it can do, but also for people who want to refer clients to us. So for anybody who has questions, our email or our website is on the bottom of the page, and you can connect to us through then. Thanks for watching, and we look forward to talking to you. Thank you.